Good afternoon, Dr. Jonathan Hill and Dr. Ho Kee Woon. You're live on air. We have a great panel here. Just quickly introduce Sophian. We have a neurologist, Dr. Professor Chang, Kim, and Ivan, and Michael, Paul Ong from Tan Tock Seng, Andrew, Dr. Park, and Dr. Sharma and Aaron Wong. So, thank you. Please go ahead and present your case.
Gentleman, risk factors as shown, significantly also has chronic obstructive lung disease and atrial fibrillation on antiplatelet chest VAS score of 3. He has previous echocardiogram which shows a drop.
Kevin, we missed a little bit of the presentation because the voice didn't cut in. So can you go ahead?
So we do have an 83-year-old gentleman with history of hypertension, dyslipidemia, and paroxysmal AF, chest VAS score 3 on antiplatelet therapy. Also significantly has chronic obstructive lung disease. Next, please. He did present with angina, with angiogram initially in 2014 showing triple vessel disease. At that time, he refused bypass surgery and drug-eluting stents to proximal to mid-LED, as well as the RCA was done in 2014. Chest pain reoccurred in 2015, a year later, and we found instant restenosis of the mid-LED stents. And further layer of stents using Resolute Integrity 3015 was implanted in the mid-LED. Subsequent MIBI was negative for ischemia. He presented this time around just about a month ago with further drop in EF from 57% to 40%. Angiogram was repeated this time around, new lesions in the proximal RCA. This was stented, and mid-LED showed 80% stenosis with underexpanded stents with severe calcification. Of note, the earlier angiogram and angioplasty was not done, so we don't, in this institution, we don't have records of one of the stents. FFR was also done in the mid-LED, and this was highly significant at 0.69. We were unable to dilate with the NC balloon, the mid-LED constriction, both with a 2.5 as well as a 3.0 balloon. We wanted to deliver an OPM balloon, but because of the bulkiness, was unable to do so. So we have an unexpanded mid-LED stent as the target lesion today. This was the ECG. Currently, no ischemic changes, risk factors well controlled, creatinine normal, and HB was normal. Next. So this is the angiogram showing the new proximal RCA lesion that has been stented. Next. Next. And we would show in the next view the areocranial. We don't have an areocranial, but this shows the previous stents in the mid-LED. This is the high pressure balloon. I assume this is a 3.0 balloon showing still a focal stenosis despite high pressure dilatation. We attempted to put an OPM balloon, but this was unsuccessful. Okay, so any further images? We did also have a CT coronary angiogram in preparation for today's procedure. Maybe you can run through the images. You can see the highly calcified LED.
So yeah, what we're seeing here at the marker, you can see the red line through the very dense area of what we presume is calcification. And so with the calcium blooming artifact, there's almost complete obliteration of the lumen. I don't know if there's another shot. Is there? Yeah. So you can see here within this segment, you can see the stents, and you can see in the proximal segment of the stents there is eccentric calcium. But what in the central segment, which corresponds to the angiogram, there's a very dense area with what appears to be circumferential calcification. So I think this shows it very nicely. Just as you go slightly further down in this sort of dense segment, the lumen starts to reappear. But certainly the mechanism here of stent underexpansion, I think, is confirmed on the CT as caused by a napkin ring, a concentric napkin ring of calcification. Very focal, and this is the reason for the unexpansion.
So this was the risk scores, the surgical risk scores. We have a high syntax score. So this is target in the mid LED, an underexpanded stent. Maybe we can switch over to the angiogram, and we will show you the images that we have today.
Okay.
Then let's switch over to the angiogram. We can play that.
Okay.
Okay.
Okay, so we just go through these pictures here. Let's just play. Okay. Okay. And you can see the constricted area within that stent really projected beautifully here. What you can notice, if you just look at the proximal segment of the stent, there is eccentric calcium, so above the stent. Then you can see this sort of dense area of opacification around the constricted area. And then there is another area of eccentric calcium on the lower side of the stent. You can really appreciate it here that there is eccentric calcium in the first half, a concentric ring, which is in that very focal segment, and then another eccentric segment on the other side. So it's been shown on CT, and we've shown it very clearly on angiography. The quality of these systems now is so good that, in fact, I'm not going to say it in front of Giulio, but you almost don't need intravascular imaging. But of course, we have done some intravascular imaging. And we've taken a guideliner in preparation because knowing that an OPN balloon was difficult to cross, and in fact, it was really quite difficult to get the IVUS through. But we did manage to get the IVUS through with some guideliner support. And what we're going to do is switch now to the IVUS images. And so we can just play the IVUS from the beginning. So switch over to IVUS, please.
OP then.
Switch to IVUS, please.
Okay, sorry.
Make the IVUS the main.
Yeah, just make it the main screen. So we'll just play it through, and I think what we're all expecting to see is a very tight concentric region. We certainly have confirmed that there's calcium in this tight region, which is extrinsic to the stent. We're getting into this very tight segment here, which you just see here, and then opening up again. So I wonder if any of the panel members have a view. I mean, is this sufficient confirmation as that the mechanism of stent failure here is extrinsic calcification?
So maybe Dr. Kim.
Yeah, this is a JS Kim from South Korea. I think a definite stent failure mechanism is underexpansion. So I think it's a very difficult situation because two stent layer and calcification. So I think we usually need some. In my situation, we usually do the rotablation.
Okay.
So maybe you can ask Andrew Ong from Australia. Do you think rotablator user, do you think it will work? Because there's two stent layers now.
I think in 2020, if you have lithotripsy, which is something that is new to us as well, it definitely would obviate the need to do rotor stent. Even though this is a chronic stent, it's been there for a while. I think intravascular lithotripsy is a safer procedure than rotor stent.
But if you didn't have that device in your lab,
if you didn't have that, then you have no choice. I think
you will rotablate.
You can do that, yeah, or you can do OPN. You can try OPN because now with the guideliner there, you're probably going to be able to deliver the OPN. But otherwise, you have no choice but to rotor stent it.
Okay, yeah. Any other opinions, Paul? Quick opinion. Yeah.
Haven't done that in Singapore, but in my previous practice in UK, sometimes we'll put a laser down and create some bubble outside the stent and see if we can fracture it outside. Yeah. But sometimes they fracture the vessel as well.
Okay, Jonathan?
Okay, so, well, we've got the IVUS, but of course, because I'm doing the case, it's going to be OCT. So we'll switch to OCT, and I don't know if you, can you see the OCT
Switch to
projected now?
OCT. Just hang on for a while.
No, hold on.
OCT.
Yeah, we haven't got it yet.
Yeah. Yeah.
So-
All right. Good to go.
Okay, so here we've got a nice view of the vessel. You can see this constricted segment. So we're coming into this very constricted segment. And you don't really see much detail beyond the vessel wall. There's 2 layers of stent. I'll just put on the co-registration just because obviously we know where we're looking at. But this is we've done this as a co-registered image. And so this is the target zone where we're aiming for. I'll put on the lumen profile. And we can see here that the MSA is 0.73 with a reference area beyond of 7.08, 7.25 approximately. So 90% underexpanded. So really a critical lesion created by this overlapping stent point, which happens to overlap at the point of concentric calcification. I'll put on the rendered stent because this makes it look, here's the apposition indicator. Of course, it's fully opposed, but here we see a very striking view of the constricted stent. This, I believe, is calcium. I've absolutely confirmed that on CT. So let's have a little fly down through this artery. I think you can all appreciate, here's this area here. I'll put on the lumen marker here. And we'll just take a fly down through the artery. The yellow marker is where the most constricted area of the vessel is. So we're here getting into, and this is the tightest region we're just flying through just now. So I think that this is a good target for intravascular lithotripsy. And so what we've done is we've sized the vessel, and we're using we can switch back to the angio and to the table. We've sized the vessel, and so a 3.5 balloon. We're using an external elastic laminar sizing where possible. And so we're now we've got the shockwave ready to go, and we're going to do the setup live on camera. Hopefully the box is charged. So if somebody could turn the power button on at the top. If you come over here, and we're going to, somebody turn the power button on at the top. Okay. Now, just if we can see the catheter, and we'll do the setup of the catheter. So we just pull this out. Okay. And we'll just do the connection now. So getting ready to, so we take off the red marker, and then we're going to connect it there. Trying not to touch the end, so keep this inside, so to keep it sterile. So it's a magnetic connection, simple to connect. Now we're just going to put a clip on there. Now we could ask somebody to press the button at the bottom. That's it. And what we'll see, so the button on here goes green, so that's button number 2. The catheter is now activated, and we're going to put this in. So if I just show you the catheter, I don't know if we can see, if we can zoom in on the catheter. I don't know if that helps. Maybe turn the light off.
Yeah. Yeah.
Okay.
Yeah,
So you can see the catheter. I mean, in terms of its profile, a bit less than an OPN balloon. And given that an IVUS probe has gone through, I think this should go through. So let's see. We're going to inflate it to 4 atmospheres. And we've prepared this with contrast, 60% contrast and 40% saline. And it's it's a monorail balloon, so it's easy to insert. And let's see. I'm not going to put the guide liner in. Let's see if it goes in without the guide liner. So getting a little bit of resistance there. I'm going to put the guide liner in. So that's right up to the lesion. little bit of resistance here. Let's just get this guide in. So fairly stiff. And let's hope that this passes. If it doesn't, I'm going to take a 1.5 balloon, which it's not going at the moment. I'm going to put this right in. Yeah. And no, it's not going. So some resistance here at this part of the stent. So I'm actually just going to balloon this segment as we go in. And so if you can give me...
Trio?
Yeah, a 3O balloon.
NC trio?
Yeah, an NC3O.
NC trio 15.
So it's not actually getting caught up on the lesion itself, but on some area proximal. There's probably some protruding stent struts because of the calcium in that segment. And then once I've dilated that, then I will bring the guide liner right onto the lesion. And then if it still doesn't pass, I will take a smaller low-profile balloon, which would say a 2mm balloon, to make a little passage for it. There's resistance here, actually.
Strange.
Yeah, this guide, there's something going on with this guide liner. Just go up there, please.
Hold on. So it's connector.
Hold on. Yeah.
Okay.
Let's wait.
Right.
No. Yeah, this guide setup is not ideal, but let's see. Right, 1 second.
Right.
I'll just pull this back. I'm not going to dilate this segment. Just go up there, please. Wait.
Flaring. 16.
Okay. And down. I'm just reinserting the
Opiate.
shockwave after this. One of the things we found is sometimes that the interaction of the balloon with the guide liner sometimes prevents you from advancing. In about 10 to 15% of the cases, in Disrupt CAD 1 and 2, we had some difficulty crossing. So we used a 1.5 balloon, and then occasionally a 2mm balloon has been used to aid crossing. Of course, the use within stents has not been systematically evaluated now, but there are lots of cases that have been done. Oops, who did that? Nobody saw that. Okay, so I've got the guide liner right on it. There's quite a lot of resistance in this 6 French system, and at this point it's not advancing. So there's something I'm going to change the guide liner system.
Jonathan, is
Yeah.
Paul Ong here.
Hi, Paul.
Hi, Jonathan. Just share with us, guide liner, the compatibility. The 5.5 guide liner wouldn't be compatible with the shockwave balloon.
I don't think so, but I haven't used that. So the ones we've most commonly been using are the Guidezilla and guide liners. So I'm not quite sure why that's not working, but I'm going to just try without. And was that a guide
liner?
Guide liner. Do we have a Guidezilla?
Yeah, 6 French Guidezilla.
Yeah. But can I have the? Let's just give me the balloon, and we'll see We'll see if I can wiggle this in. Certainly when we saw that fly through, you could see that there were lots of, before you got to the tightest region, there were lots of struts protruding.
Perhaps while you're doing that, I'm just going to ask the panel, anyone, how much experience does the panel have with lithotripsy, actually? It's a fairly new technique in the region, so I'd be interested to know how many of the panel members have actually used it and what the experience has been like while we watch. Anyone volunteering? Paul?
We did a bit in our hospital.
I have a 3.5 NC balloon, please.
3.5 NC.
And it, you know, one of the things is obviously, you know, imaging and sizing the balloon. And I think that's one thing we noticed when we first brought it in. We worried that it's going to be bulky. We worried that it won't track. So we actually ordered a lot of 2.5.
So we may have to upsize.
But once you get going, we noticed that the commonest balloon size that we're using are largely 3.5 and 4.0. I think that's something to bear in mind.
Extra support. This was Xiong Blue ES, another Xiong Blue
What's
ES.
the experience, Aaron?
Yeah.
Xiong Blue ES. Yeah.
So I'm going to put in a buddy wire. The resistance I'm getting is actually at the ostium of the stent with the shockwave balloon. So I'm going to do a little bit of post-dilatation. I'll put another wire in, and then we'll try again. If necessary, we'll try with another.
Same with Paul. The sizes that we use usually is about bigger size, 3.0 and 3.5. Yeah.
Andrew?
So we've got a limited experience because we've only just got it. It's not fully registered in Australia yet. But we had a similar case where we had 2 layers of stent, like this one, in the mid-LAD. You really need to prepare the lesion well in a way to get, because the balloon's quite bulky, go down. But it was very effective in a similar case like this. Perfect, you know, no residual stenosis after lithotripsy.
Okay, I'll have the 3.5 NC balloon, please.
3.5 NC.
Ivan, your side.
We can just give me the vessel size in the proximal segment of the stent there, just from the OCT. If somebody could just do that measurement for me.
Is this available in Korea, Dr. Kim?
It's not available in Korea.
We're working on it.
But my question is, what is the mechanism for the lithotripsy in this case? Because just already stent, then just this device is crack the calcium behind the stent. Is that right? Just remaining the stent. But rotablation usually rotablate all things.
Yeah.
Yeah. But in this device, just remaining stent and just the behind the calcium.
Yeah, the calcium should be cracked. Yeah.
And then expand. Is that right?
Yeah. Jonathan, is that the mechanism? Is to crack the calcium?
Yeah. So it's calcium fracture. I just want you to. It's not advancing beyond here. Just if you can go up there, please.
Small inflation. 12.
Down. It's interesting where it's actually catching.
Some tortuosity as well.
And up there, please.
16.
16. And down. And okay. If you give me a 1.5 balloon, please.
1.5.
Yeah.
15.
So I'm going to just take a 1.5 balloon through.
Jonathan, is there a role for like doing like a leopard crawl
just
kind
take
of
it.
technique
Sure.
to use the
Right.
IVL balloon to try to ablate proximally little bit by little bit to get into the lesion? Does it work?
Say that again.
I mean, can you do like a leopard crawl technique where you, ablate a little bit proximally and then try to get in?
That's exactly what I'll work up to.
1.5.
But I'm going to just do some dilatation now with a 1.5. Now, because the OCT has gone through, this should go through. I haven't yet got a guideliner back in, but we're getting a guidezilla ready. So I think sometimes this sort of preparation, it sort of flattens down. So that's going very easily. So we're going up there.
16.
And down. So I'm going to see if it goes now without a guide liner. If it doesn't, we will put a guide liner in. If that doesn't work, I'll do a 2mm inflation with a guide liner. And if that doesn't work, well, I'm open to suggestions. Yep.
The other option is maybe if you just want to
2mm.
ablate that tight area, use a smaller IVL, maybe
Yes,
less
I think
bulky.
that's a good suggestion.
Yeah.
So if we do get a 2.5 ready, please.
2.5
Shockwave. So I think this really gives you all an impression of the deliverability issues that there are. Okay, so that's getting caught up at the ostium again. I'm trying to push here, but it's really not yielding at all. So we're going to do guide liner and a 2mm balloon.
Let's go back with the guide liner first.
So, Jonathan and Woon, we leave you to work on it for a while.
Sure.
Please record this, and we'll try and come back as soon as we can.
Yeah, great.
Yeah,
we'll record every step.
Woon and Jonathan.
Hi.
Hi, we are back with you.
Yes,
So,
we have lots to show.
Okay.
But we're just doing a OCT run.
Well, why don't we just show them what we've done? We'll do the OCT run live.
Sure.
So can you see the angios?
Yes.
Okay. So we were going to pretend that we've been sitting here doing.
Can you switch to angio again? They put on the OCT.
You got to be very patient.
Okay. So this is where we started. Dense calcification, concentric ring, difficult to get imaging catheters through. But the fact that we got an IVUS through and an OCT, I thought that the IVL balloon would pass. However, it didn't, so lots of maneuvering with balloons to get guide liners into position. We've changed the guide liner size. We went from a 6 and we upsized the guide to a 7. We went to a 7 French guide liner. But really, so this is right at the ring, so can't advance this any further. You've got a 1mm balloon goes through. And that passed easily, but then it was always a question of then this is a 2mm balloon, and we still then couldn't get a shockwave balloon through. So that's a 2mm balloon. Again, NC balloon this time, and then we've got the guide liner here right on the lesion. Now you can still see the constriction at the distal third of this vessel, and then finally, this is a 3.5 balloon that goes through, but it's still constricted, so we still haven't been able to get the shockwave balloon through. So lots and lots of maneuvering. We really were fighting with this vessel. This is an OPN balloon. We tried to get the OPN balloon, wouldn't go through. So that's another 3.5, and this is finally getting the shockwave balloon into position. So
2.5.
And we took a 2.5 balloon. I think that was Philip's suggestion. So this is the tip of the balloon, and we're just applying as many shocks as we can. Remember, it's quite a small balloon, so relative to the size of the vessel, it's not going to be touching the sides before and after the lesion. But you can probably get the discernible increase here in the diameter, very marginal. Then it's coming up a bit more here.
Yes,
so
it looks more obvious now. Yeah.
It's more obvious now. It's less wasted. So this is now a fully expanded 2.5 balloon. Now we put in a 3.5 balloon. And so this was actually I managed to get the guide liner right through, which we could not do before. And so then we were able to guarantee the delivery of a 3.5. This is a 3.5 balloon in place. You can already see the stent is expanded. So 3.5 is now coming up. We're giving lots more shocks here. And so probably we've given another 70 shocks. And that's what we've got now. So the narrowing has gone at that point. We don't think we've got a perforation, and we're just about to do an OCT. So if we can show you the OCT, we'll just do it now. Okay. So guide liner is in position. And we're on...
Yeah, we're not seeing the OCT yet.
Can we bring the OCT up?
Yeah.
Yeah.
Yeah, they got
Thank you. Yeah, we can see that now.
Okay, give me a little test injection. Yeah, nice clearance.
Okay.
I'll just auto-calibrate that now.
Okay.
I'm on a high resolution setting. Enable pullback. And inject. Okay.
This is nice.
Yeah, I'll go to the console now. You just take the OCT catheter out there. And we'll do the co-registration.
Yeah, but from the bottom cartoon, we can see that, you know, the waistline is gone.
It's gone, hasn't it?
It's beautiful.
Hi, John. Congratulations for your good cases. I'm from Yoshi.
We've got a dissection at the beginning, though.
How many times did you activate the shockwave button of this 3.5?
We used we did full 80 runs. So this is the region here. So this is where we were constricted. You can still see some of the sort of misshapen indentation of the calcium. Here you can see a little bit sort of calcified nodule, but this region is now fully expanded. If I just look at the area within that, so the MSA here, 6.9, which is just beyond this region here, is actually slightly more expanded than that. So we've achieved full expansion in that segment.
It's a very dramatic gain in cross section, right? So early on it was less than 1.
Yeah, it was 0.73, I think. I think what was helpful here was the suggestion of taking a smaller balloon. So this is a dissection at the ostium of the LAD, but we've had lots of guides and guide liner going in there. So we're going to have to deal with that. But this area here, if you can see, where this is the area that we've addressed.
Jonathan, Nigel Jepson, we've got a fair bit
Nigel.
of experience using laser for this. Obviously, balloons are much more familiar with us all. I'm not sure the time frame from these old double-layer stents, but a lot of the ones we've done are quite remote, no drug on the stents, and we finish with a drug-eluting balloon. Is that your approach in this sort of situation?
Yeah, Nigel, I think that's the right approach here. I don't think more metal is what's required. I think some drug is required here. We're going to put a stent in this segment here, of course, but I think this segment here, I think we'll apply drug-eluting balloon, and then we'll be finished.
So Jonathan, I presume will be high pressure over that same segment, just to open up a little bit more, and then DEB, or you're just going to go DEB now? You think you've done enough?
Yeah, I mean, I'm always reluctant to go to very high pressure. Are you meaning sort of with an OPN in that region?
No, just NC balloon and just go higher pressure on that, or you think looking at IOCT looks pretty good?
If you're looking at this view of the stent, in fact, this is a fully expanded stent. Looking at the Illumin, these by the Illumin 4 parameters, your distal lumen here 5.2. Coming up here, I don't think there's any further expansion that we can do in this region. There may be a little bit of asymmetry, but it's well expanded. And in fact, you've got a little bit of vessel trauma here, probably from the ballooning of the high pressure balloons when we were trying to dilate it before. So I think I'd be happy with this, apply some drug, and we'll sort out the proximal end. But I think that's quite a nice demonstration, even though it was a bit of a struggle of getting the shockwave balloon across. But I think we confirmed the diagnosis. It was calcific constriction, and shockwave balloon, I think, has really done its job.
Jonathan, this is Chu from Malaysia. Just a quick, I mean, this is probably one of the best results and main reasons why when you use IVL. it's so powerful they can break the extrinsic calcium. I just wonder, have you ever seen any stent fractures at those areas?
Well, it's a really good question, and I think it's one of the concerns the company has, and they have a little bit of in-house data suggesting that there is a process of pitting on the surface of the stents. Now, we've not seen that, and I have not seen that experimental data, but in theory, there is a potential for damage to the polymer certainly of a freshly implanted stent, and damage to the metal itself. I think one of the concerns is that the electro-polished layer of the stents is pitted in some way. So, that potentially can set up a sort of differential current between the surface and the metal underneath. But I think this is all theoretical, and I think it needs to be looked into further, because this is actually going to be a very important application of IVL, whether Shockwave like it or not.
Are there any limitations to in-stent restenosis in terms of using the IVL?
Well, the limitation you saw here was deliverability. So, but that's the same issues that we face with other, more bulky devices. Certainly, we couldn't deliver an OPN balloon here. I think currently that's its major limitation, but I think we can overcome that with most of our sort of extra adjunct techniques, guideliners, and more supportive guides. And so I think that's something that can be overcome and will be overcome in due course with further engineering. And certainly there are lots more lithotripsy loaded devices that are coming in down the pipeline.
Thank you, Jonathan. Thank you, Woon. Great case. I mean, we're going to switch back to the room. Is there any parting pearl of wisdom to drop us before we move to the other room?
My plea would be, if you're concerned about calcium, then confirm the diagnosis with intravascular imaging and be absolutely precise in your assessment of the vessel and what the right tool is. So intravascular imaging where possible would be my message.
Okay, great. Thank you very much.
Thank you.
I think we need to give Dr. Jonathan Hill a big round of applause. He's extremely experienced in the IVL program, and he's got, I think, more than 300 cases under his belt. So really a great demonstration of this technology.
Yeah.